Welcome, everyone. Welcome. Just giving a moment to join. Eamon is going to lead this conversation just to kind of start us out and do a great welcome. But my name is Vesper Moore. I'm the Chief Operating Officer from the Kiva Centers, and I'll be presenting on Soteria Las Cruces today. I'm going to pass it over to Eamon.
Thanks very much, Vesper. Hello, everybody. My name's Eamon Flynn. I run a local Soteria network in London, Soteria London. We are a small community. We do lived experience, family and friends. We do a lot of lovely creative activities of music, art, and we got a monthly kitchen going. We aim to do some build up our community, and who knows, we'll start pitching to set up a house or two in London. That's us. I also just want to welcome some people from Soteria Network UK and the research team. I know Rita's here or Jen Killian. We um, we actually did a pitch in with the Greater Manchester Mental Health Trust, who are doing a research into feasibility of our own NHS funding some Soteria houses, the results of which are going to be published soon, and we're going to be very excited about that. So that's that. I'm just going to say hello. I know there's some people just here from Europe. There's some people here from Belgium. There's some people from America. I'd just like to say hello to the HMV mums, the warriors. Good to see you. And I'm just going to introduce Vesper Moore. Vesper works for the Kiva Centers, who've done an awful lot of work setting up this Soteria La Cruces house in New Mexico. So what we're going to do, Vesper's going to talk for 30, 40 minutes, and we'll have time for questions and answers, maybe quarter out at the end. We expect this to run for an hour. So welcome, Vesper Moore, and thank you so much for making
Hello.
time to tell us what you're up to over there.
No, this is my.
Thank,
Uh,
Thank you for inviting me to have this conversation and for really leaning into the broader network aim. And I'm very excited about the work you all are doing in London, and excited about the work that a lot of folks who are also joining the call are doing in different parts of the country as well, beyond Soteria. And so I will briefly describe the work that we do at Kiva Centers. We are a peer-led organization, which means we are led by people with direct life experience, usually survivors or users of the mental health system. We have been around since 1987. We started as a group called Empower that was founded by Judy Chamberlain and Pat Deegan in the 1980s. That started as a group of ex-patients during the time of deinstitutionalization in the United States in the 70s, really as a result of the civil rights movement and people broadly within these systems being warehoused and not receiving proper services because a lot of these institutions were either understaffed or didn't really follow a person-centered model of care that did lead to violations and abuses in the United States. So the effort amongst this initial group was basically can we build our own services as people who have been service recipients? And there was a whole movement behind it, consumer survivor, ex-patient, ex-inmate movement. And I think as an extension of the civil rights movement and the disability rights movement, the Americans with Disabilities Act passed. We have a decision, a Supreme Court decision called the Olmstead decision in the United States, which means people with disabilities have a right to live in society desegregated from institutions. We shouldn't be using institutions as a means of segregating people. And with that, in the 60s and in the 70s, and in all the moments leading up to a lot of this work that you see in the 70s and 80s, that initial push was the creation of alternatives and really the growth of alternatives, which in the US, we've seen a further growth with we now have over 45 peer-run respites in the United States. We have numerous peer-run drop-in centers, 33,000 certified peer specialists, people with direct life experience doing the work. And we have Soteria houses now expanding and growing. Over the years, we've had Soteria Vermont, Soteria Alaska, Soteria, the initial Soteria model in California, in San Jose, which started through an experiment with Lauren Mosier, which really is kind of the inception of the international Soteria model. And over the years, as we've led to now the Soteria House in New Mexico, we've seen the growth of these ideas, but not as much investment in community-based care. There's this a consistent push to how do we treat and yes, address emotional distress, but instead of how do we build community-based approaches that improve quality of life. Um, Lancet Psychiatry has a few different studies that reference 85% improvement in rates of wellness when you center social connection and relationship building during early psychosis. We see the work of a Rogers model of person-centered care in the 1940s and investments in these approaches. And we see a lot of these ideas of how can we address psychosis and address emotional distress really from a community-based and relationship building perspective. In the New Mexico legislation for Soteria Las Cruces and Kiva's work on that legislation, we really phrased, because New Mexico is really keen on it being phrased as an early psychosis treatment approach, even though we think of it as community building as the methodology for what we would often call mental health care, for what we would often call a lot of these things. But we rephrased it as if you're going to call it treatment at all, it's truly relationship building and social connection during these early experiences. And that is the key benefit there. And we've seen this work at Kiva Centers over the years because for the last 7 years we have been operating peer-run respites. We operate 3 peer-run respites, one named Coraya, one named Juniper, and another one named La Paz, in Massachusetts in the United States. So very different communities between New Mexico and Massachusetts. Actually, Massachusetts in the United States ranks consistently first in mental health care, and New Mexico constantly ranks last. So our hope with bringing this innovative approach, Soteria House, to New Mexico is to really support and build these ideas of alternatives beyond, a lot of the models that are more popular in the United States, because we have community behavioral health centers, we have behavioral health urgent, care, through clinics. We've got behavioral health clinics and private practice, and so many different forms of mental health care that exist in the United States. And but by having community-based uh, models and the idea of Soteria, which is again that relationship building during early psychosis and self-determination around medications, which is what we do at our peer run respites, which is people would have the option to taper with an available tapering protocol, which is run by our psychiatrist Rupi Legha, and is supported by our licensed mental health counselor Ike Trevino and our 2 directors, Megan O'Leary and Nora Candelaria, who are actually flying up from New Mexico to Massachusetts and couldn't be here today. But presenting on their behalf and just saying that this is it's a multifaceted effort. Our direct support staff, the way that we like to operate our Soteria House, our direct support staff are people with life experience. So the people who interact, who do the groups, who do the support, even though that's not necessarily what the initial experiment called for, that is how we are operating it at Kiva Centers. And then the other exciting aspect of a lot of what we're doing is I think when you think about Soteria House, you need dignity of space and privacy. So people having their own rooms, having that autonomy, that space, group facilitation, and groups around hearing voices and general peer support groups are so important. We do groups on peer support around extreme states is how we refer to it. And for us, we do them within the house, and we also have groups in the community. So when folks come out, they can go to these groups. Once they've benefited from their time at Soteria, they can continue to receive that support in the community, so they don't feel like they need to be in a place again where they're struggling and they might need to utilize either a resource like Soteria or otherwise. So for us, when we think about this model and what we're doing in the Las Cruces community, it is really thinking about how are we reaching people who are experiencing extreme states on the streets in Las Cruces and in their homes and in many different places. Currently, Las Cruces is a community that has high substance use kind of struggles in that community, particularly opioids, has high domestic violence, and and is a very I would say is a very spiritual community, and a lot of people who might not appreciate the more traditional approaches that might exist within the behavioral health system. So so Soteria is the right fit for this community in a lot of respects. Um, what we are noticing, and just in kind of our work and in the communities that we're reaching, is we're reaching a lot of mothers that have experienced postpartum psychosis through just our initial mobile work, because even though our house isn't accepting guests quite yet, because we're just getting through our licensing stages and all the things that are needed for the house. Um, During our mobile work, meeting with folks in the community, we're noticing postpartum psychosis is a large issue in the community, and we're noticing that grief-related psychosis, so people losing a loved one, a lot of folks not necessarily having the initial diagnosis, but needing the immediate resource, is another piece. And I mean, naturally, because we're in 2026. It is not the 1970s. A lot of people are coming in using psychiatric medications. Some might want to change or reduce and not necessarily taper. So we're really focusing on self-determination around psychiatric medications. That's really our ideal approach. And again, our psychiatrist, who is both an adolescent and adult psychiatrist, supporting guests coming into the house with what they need, as well as folks who are receiving mobiles. Um, the work that we've seen through our peer run respites, we have supported thousands of guests who come in and manage their own medications. They usually keep their medications in a lockbox. They stay for 5 to 7 days, but we have a lot of folks who stay for a month at times when they really need it. So the difference, I would say, between the peer run respites we operate at Kiva Centers and our Soteria House is the length of stay is longer. You have the 3 to 6 months um, naturally, but if someone wants to stay for a month or a less amount of time, and they feel like that's what they might need from this method of care and approach, that is absolutely fine. New Mexico does function off of insurance-related billing in terms of funding. We did receive initial funding from the state legislature through it's referred to as a procurement bill, which are bills specifically related to procuring funding, which was sponsored by a legislative champion, actually three legislative champions who really believed in the model and the approach. I would say the advocacy wasn't easy. There was about 20 years of advocacy in New Mexico, led by psychologist Dr. Al Galves, led by our advisory committee, folks like Carol Kane, who operates another model called Oxford Houses, which are related to substance use recovery, and really, as well as so many other partners who have been doing this work for a long time. So I think when we talk about what is the effort around Soteria Las Cruces and the work of Kiva Centers in this community, that initial advocacy was important. Having a network, like Eamon was talking about earlier, to initially discuss what that model looks like, thinking about funding strategies, um, leaning in and understanding the community need. And when we talk about extreme states and or psychosis, what does that look like? What are some of the gaps, especially in your community, in terms of people receiving community-based support around this? And I mean, Soteria is truly an alternative. It's an alternative that's that is seeking to kind of subvert and defy how we understand um, approaches for people who are often labeled as seriously mentally ill. You know, I mean, this is not terminology that we use for our community members. We don't necessarily, we are not going to label them as seriously mentally ill. I'm using the term psychosis right now, but often we use extreme states to describe the experience, or we reflect what that person is referring to their experience as. I think it goes such a long way when you are approaching this from the perspective of what are the social outcomes that this person needs in their quality of life. When we think about what Soteria, the original intention and the study and what was effective, it was really having it be a community living environment where people are there at the home, but they're like also sharing responsibilities around the house. They're working together. They're doing all of these things together. So we predict that a lot of our groups and activities, which is true for our peer-run respites and peer-run drop-in centers, will be done by guests and staff who are working together, who are taking that time. In terms of what the actual care and the time looks like, we understand that that will be built out with the guest in depth for what they're looking for in that time. Folks will not need a diagnosis of schizophrenia in order to come into Soteria, but just identify with that experience of extreme states and psychosis. Because as I said, there are many life factors related to trauma and social environment that can lead to someone experiencing psychosis, as well as sleep deprivation, many, many things that lead to these experiences. So we believe that by coming at it from this social perspective, we will be able to reach a broader populace that will really need these supports. Folks will have the option, once again, coming in to be able to come off of those medications if they so decide to, and or reduce, the dose. I can't tell you how many times people come out of a psychiatric inpatient acute unit or many other resources and have their medication substantially increased. And after that life disruption, they're not able to return to work or school or continue to do the things that they were doing before. So we do believe that by including this as a part of our methodology, we're able to support that broader range of people once again. When we talk about Lauren Mosher and Voice Hendrick's initial work, Lauren Mosher did talk about how the American Psychiatric Association became the American Pharmacological Association. And one of the reasons why it was described in that way is in the 1940s in the United States, you saw these ideas of initially bringing on person-centered care. You saw an expansion of it in the 1960s. You saw this approach where society was taking a critical look at the mental health system and psychiatry and broadly the abuses that had taken place behind locked doors, as I had just described to you all earlier. And we had a civil rights reckoning. Once again, the Americans with Disabilities Act, Olmstead, all of those were related to pre-existing Supreme Court cases and some of the longest civil rights demonstrations in United States history, such as the 504 sit-ins. So after that reckoning, it was like something needed to be changed. And we understood that that change had started. There was a halt in that process. And prior to the current federal administration in the United States, we had continued some of this work in terms of expanding some of that same progress from the 60s and 70s. Uh, However, regardless of I would say the federal administration's perspective on mental health care and treatment, Kiva Centers, and a wide variety of organizations in the United States, we are continuing to find ways of funding and expanding this work through private and public funds. Um, and we are also looking at many additional options when we talk about the continuing research around Soteria in the United States. We are partnering with the University of New Mexico, and we are partnering with several academic partners to do research over the next year to really talk about the work being done at Soteria Las Cruces. And we're excited. Our initial training was done by folks at Soteria, Vermont, who have been doing this for 10 years through Pathways Vermont. And we have been starting to really connect with the broader international network through ISPS and other partners, as well as talking to Eamon and Soteria London. I appreciated Eamon reaching out to connect with us, because I do think when we talk about this internationally, I do believe when we think of the United Kingdom and we think about some of the early work that was done around social approaches to people who experience psychosis, you you have a groundswell of great work that was done that didn't necessarily sustain and didn't and some of which wasn't viewed as a success. Namely when we talk about the Kingsley Hall experiment and some of the work. But really, when you look at some of that initial work, you see R.D. Laing's struggle with alcoholism. You see understaffing in the house. You see the level of community integration initially was a struggle. So not a lot of the groundwork that needed to be done. Um, you see a lot of these things. And right now there's a peer respite being opened in Iceland. And it will be the first one in Iceland through the Icelandic Mental Health Alliance. They just secured funding for that. And the Netherlands is interested in peer respite and Soteria houses, as well as Iceland being interested in adding Soteria House into the equation. And they're natural partners, I will say. Because peer run respite, you have shorter term stay for all people who experience mental health crisis. Soteria houses, you have a little bit of a longer term stay for people who are experiencing extreme states in psychosis. It is invaluable to have these social approaches in your community. And I think whenever I hear a lot of the initial concern about community-based approaches, what about the liability? What about danger? What about some of these factors? I like to say that there is more of a present danger when people are under-resourced and on the streets in your community than when they are integrated in a community-based environment, when they have three people at a time on the team supporting them. So we'll have three staff at all times. We have two managers, and then we have our psychiatrist and our licensed mental health counselor. And we'll have five people at the house, and we will be doing mobile work for every person who is waiting. And we can see that the community need is high, and we already see a positive impact with the guests we're visiting. A lot of folks who are like, I wasn't sure who to turn to at first. When my father died, I had started hearing his voice and I felt so alone. Thank you for meeting with me, taking the time, facilitating these peer support groups and doing one-to-one sessions. I look forward to coming into the house. That was one guest who is currently living at his father's house. His father just passed away, and he has been having this experience with hearing his voice and being alone in this house. He does not have a formal diagnosis yet. He is struggling with this experience for the first time, and we're going to see numerous examples like this. And again, we at Kiva Centers, we already know that this is prevalent because through our work with peer run respites the last 7 years, we have seen a lot of guests who start to hear voices, experience extreme states, who don't have a formal diagnosis or do, and there aren't significant resources in the community to be able to, one, discuss, have a community-based approach, and not have to fear their civil liberties or human rights being stripped away, being in a locked environment, or not having self-determination around their medications. This is the work of Soteria Las Cruces. We're really looking forward to the year ahead and the years ahead. Um, we're close to 30 minutes in, but I think that sufficiently covers our initial presentation, and I'd love to open it up for discussion.
Thank you very much, Vesper. That was a really inspirational talk. I liked the fact of your amazing long experience already with the Kiva Centers and the peer respite centers has fed into your knowledge of working with the community, staffing and training, and also your advocacy and getting funding or advocacy champions within your own legislation, which sounds an incredible, huge piece of work for you and your team. So congratulations and well done for all that. So I'm just wondering now how if people want to raise any questions. If you want to raise your hand, see if we can spot you.
Absolutely.
Diane Elliott has raised her hand. Diane, if you want to unmute yourself, please.
Hi, thank you, Vespa. That was very inspirational. Thank you so much. Yeah, I'm based in the UK and I'm coming from a transpersonal psychology perspective where we often explore the distinction between what's sometimes called psychosis and what might be understood as spiritual emergence or even spiritual emergency. So there's a growing body of work suggesting that some of these intense experiences, they may not only be pathological, obviously, but they could also have meaning, maybe even developmental potential or transformative value when properly supported. So I'm really interested in how this might align with the Soteria approach, particularly your emphasis on relationship, community, non-pathologizing care. So have you come across this distinction in your work? And maybe if so, how do you navigate the language and the support around these kinds of experiences?
Thank you, Diane. There are a lot of, I would say, examples of guests we have supported over the years who have had, um, I would say, experiences that parallel a level of truth of a traumatic experience they have had, and they end up either seeing things or hearing things that relate back to that traumatic experience. So, for example, we have one guest that we're doing mobile work with in New Mexico. Now, Las Cruces is right on the border of Mexico. There's El Paso, and then there's Juarez, which is a huge city in New Mexico, or in Mexico, and that city recently had a lot of issues with the cartel, a lot of traumatic issues. So one of our guests has a previous domestic violence relationship with someone who was involved with the cartel. We didn't know that initially. They ended up processing that through their discussions, kind of getting into the truth of it, because they were describing their experience as being followed by the cartel, not being safe anywhere they went, constantly being vigilant of this, and that there were parallel, factual, traumatic experiences that really relate to the hearing voices and the extreme states. So, with that being said, I would say from our perspective, we see we seek to understand the experience first, and I'll say from a religious and a spiritual perspective, the Las Cruces community is I would say very, very broadly a Christian spiritual community. And and there are a lot of folks who I think are mainly Spanish speaking that might be having these religious and spiritual experiences that they might not yet be able to interpret and understand. Some of them might involve hearing voices, some of them might involve something else. And our way of understanding and the way in which we are phrasing it is in the United States, there's this approach. It's called, or rather, a framing. It's called the eight dimensions of wellness, which are many different domains when you focus on well-being overall, right? Environmental well-being, occupational well-being, spiritual well-being, right? So we'll focus on spiritual well-being, and then we'll say that some of our time is that the guest might be focusing on their spiritual well-being, whether if it be through conversation, connection of resources and what they want to focus on. And maybe they're interpreting their experiences. And then in terms of diagnosis, because sometimes the Medicaid system might require that something be written or something be, you can just say NOS, not otherwise specified psychosis. Um, and the guest understanding that and knowing that. And that's not a formal diagnosis that's going to follow them around. It would just be for the billing purposes. But yeah, that's really like impractical approaches, how we might take some of that work. Now, I myself, I'm not a psychologist, but I hope I answered that question well enough for you.
Yeah, totally. Thank you so much.
Thank you, Diane. I see two more hands. We'll move on to Jen next. Here we go. Hi, Jen.
Oh, hi, Vesper. It's so good to hear everything you're saying. It really resonates so closely with me and the work we're trying to do here in the UK. I heard that you mentioned ISPS earlier on that some people might know about and some people might not. So I'll just briefly say it stands for International Society for Psychological and Social Approaches to Psychosis. And some of us are part of Soteria and part of ISPS, and we're trying to bring them together. And we've now got, you might know, there's now an international ISPS Soteria group, and they're having their international conference, ISPS is, in Lausanne in Switzerland in June. So if anyone hasn't had a chance to book on, and I'm not getting paid for this or to advertise it, yeah, but that I know there's going to be an emphasis on Soteria there. So it would be a great opportunity for people that are working on Soteria to get together and share more, both formally and informally. So I don't know whether you're aware of that. Somebody mentioned you might be coming. Might just be a dream or a hope, but are you going to be there?
Thank you, Jen.
You
It's
know?
a great
Yeah,
question.
yeah.
I have a presentation with Ippy um, Kalakafonos and Erica Fletcher. We were doing hearing voices research together in Los Angeles for veterans. And we had written Soteria Las Cruces into that initial presentation. But those colleagues aren't sure if they can travel to Lausanne yet. So I'm still trying to piece out if I'll be able to make it or not.
Yeah.
I know I am excited for it. I am a part of the international network. Kiva
Right.
Centers is an institutional member of ISPS. So we look forward to being in those discussions and conversations. I hope I can make it to the conference. So thank you.
That would be great to see you there, and anyone else that's come in. We'll have a meetup. Thanks so much for everything. Yeah.
Thank you, Jen. And we
I've
have
got
Berta. Yes.
to
Eamon?
next, yeah. Yeah, I'm saying the same, yeah. But
Oh, okay.
if you want to ask a question.
Yes, thank you. I had to take my video off because of my internet weakness. I really appreciate, Vesper, how you unite across many ways of seeing and being. And I am still concerned about the need to diagnose in order to get payment. I think that your energy kind of supports mutual understanding, and it goes against the main purposes as understood by Medicaid or medical insurance. And I saw that happen in Israel too, where they kept needing to adapt in order to keep getting paid. And that has happened with peer respite too. So that's just my concern. And I wanted to say that Mosher went and spent quite a lot of time, I think, uh, with Artie Lang at Kingsley Hall, and that was the inspiration for his starting Soteria in San Jose. And he didn't do that until he retired. He didn't do that. American Medical Association, American Pharmaceutical Association. So I've been around all through these years, and I feel like it really takes a village of folks like you to be able to continue to find ways to use language that still enables emergence. And the psychologist spoke to that. Um, it's very hard when the societies are structured the other way. So I would love to hear more about how you do that translating, because once somebody has any psychosis, NOS, that has a huge impact.
Yeah.
And just as when you travel, how your passport looks, how you've been identified, that right now there's a lot of threat in that.
Hugely. There is a lot of present threat. I actually have my passport on my person, even though I am a US citizen. I have in my time traveling down to Las Cruces, when you drive through New Mexico, particularly from Albuquerque down to Las Cruces, there is border control, even though you're not outside of the country. So you get a border control kind of checkpoint. And I did have some difficult experiences being held by border control on my way down. So even I myself have navigated those tumultuous experiences even within this last year. So I will say that yes, there's so much to navigate. The ways in which I've found it effective to translate. I know during this presentation earlier, I was saying self-determination around medication. I find that there are a lot of both, I'll say, institutional professionals from insurance companies and private institutions and practicing professionals who will resonate with that language if you and some of the work has been writing both a protocol and a procedure that says folks are responsible for self-administering their own medications and or can have the supports of discussing and tapering off of said medications with their psychiatrist, but they have to consent when they initially come in. Having just an initial consent in kind of the welcoming process when folks are coming in uh, can come a long way. There is a formalization, right, that can make these things very, very, very difficult. The goal is that you don't want your guests to feel that at all. You don't want the guests to have to fill out a lot of paperwork, to take all this time. You don't want to also have a clipboard, right, where you're not looking at them and connecting, right? But you want it to be a self-determined process. So a lot of our paperwork we do turn into just like links and surveys that people can fill out. They can always click refused on everything. You can click refuse, 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 and that's great. Or you can choose to do a lot of that work. And I think in terms of how we approach things like the systemic impact of what they often call documentation, we like to refer to it as community co-authoring. If we're not writing the narrative of our own experiences in these alternatives and trying to demonstrate their effectiveness up against the large industry, the large medical industry that exists today, then it's going to be written for us. So it is the creation of our own process and always having the right to refuse that I think goes along hugely and goes along with what is often referred to as informed consent broadly amongst most professionals understand that as informed consent. Why must we be held to a standard where we then have to document like those medical professionals? No. We can instead ask meaningful questions and surveys that focus on the experience of the person and as much as they want to disclose and not the diagnosis. It can be not otherwise specified as a criteria, right, for engaging with Soteria, but otherwise, the rest is simply the experience of what the people would like to share. And I think that is actually acceptable in demonstrating engagement, efficacy of the model, and evaluation of the model. So that's I hope that answers your question. uh, it's difficult, Verda. So I appreciate you raising that as well. And in terms of maintaining the ethics and the intent and the mission of what Soteria is to be, you have to either if you're going to if you're going to engage with any formal funding, it should be a community co-authoring model. If it's not authored by the guests and it's not a process that is created in the community, and instead it is a clinical evaluation process that is enforced in that community, it will not operate as a Soteria House. It'll be antithetical to the Soteria House model. All right. We'll go to Caroline next.
Hi, it's great to hear from you, and I'm turning green with envy. I have a few questions, keep them short. Um, I wondered, you mentioned that you have like a mobile activity, and
Yes.
I was wondering, because we've had a few sessions in our Soteria London meetings about the importance of is that like a first step, or is it something that does the groundwork? So I'd like to hear a little bit more about that. I'd also like to hear a little bit more about the scale, the numbers and what you find works or doesn't work. And my third question is about allies. And I take it for granted, like places like ISPS and Soteria. Of course, they're obvious allies. Maybe not so obvious allies that you came across.
Not so obvious allies. There are many of them. Uh, the mayor of the city of Las Cruces loves the Soteria model, and his name is Eric Enriquez. And uh, you know, there's a radio show in Las Cruces. We call it Speak Up Las Cruces. And they had us interview on their radio show, and they had us debate with a more traditional therapist that disagreed with our approach. So we went and we had kind of a fun like public disagreement of like and kind of found consensus where we could. So I think that's the importance of the work is really finding consensus where you can, um, partnering where you can, and really identifying with their initial training, like and having them resonate. Because it's like, okay, at least in the United States, most therapists and psychologists and psychiatrists might operate off of a Skinner model of psychology, right? Specific talk therapy approaches, but they're not often thinking of the Rogers model approach as much, which is person-centered care. Where did we lose person-centered care? You know what I mean? How is this not aligned? I'd like to understand how you believe this is not aligned with your training is like one of the questions. I enjoy getting into that discourse and really engaging and not with an ill heart, just kind of a it's kind of like a let's discuss and really get into this. You believe this is a danger to your community, to your family, to your friends. Oh, this needs to be different. Oh, okay, why? And I'm wondering, why would you want to eliminate more options for your family, your loved ones, and why take away choice? If we're talking about informed consent, and coming into this. So there are a lot of allies that we've built along the way, and there are allies that agree with us to an extent. And we approach that very transparently. Like we will agree here. Like for example, there is there's the National Alliance on Mental Illness in the United States. National Alliance on Mental Illness is against uh, what they refer to as people with mental illness being incarcerated in jails and prisons. Kiva Centers, we are also against that. There might be some folks who believe, or a lot of folks who believe that involuntary commitment should be the entryway. We at Kiva Centers, we do not. We believe in self-determination and autonomy, and involuntary commitment is not the entryway. It is not what should be done, right? I personally did not benefit from involuntary commitment in my own life, you know? And so getting into some of those discussions, I've had discussions with family members who said, my son wasn't able to get sober until he was involuntarily committed. Oh, this. And I said, all right, well, I was suicidal and I was involuntary committed and I had a massive life interruption and more traumatic experiences coming out of the hospital than before I had gone in. So, we get into those discussions a lot and why these community-based approaches are really important. And I will say there are civil rights decisions that I was referencing earlier that support the existence of building models like these. So community-based mental health care, right? Which isn't always voluntary, right? But the way we do it is. Um, that within itself you can really signify and say that the reason why that exists in the context of the United States today is because of the Olmsted decision, which, as I was saying, is the right to live in community desegregated from institutions, persons with disabilities as a whole, which includes, within the definition, people who experience emotional distress, whether or not if they identify with disability, they are protected by that civil right. Right. So acknowledging that and, and then engaging in that discourse of like, why would you believe then involuntary commitment and segregating people and institutions is the right mode forward? Because clearly it hasn't worked for us before. It's not going to work for us again. And that's why it's important to have alternatives and these models built. In terms of defining Soteria House itself, and really engaging around that model, it is one saying this is the work and the approach in terms of when you talk about people who once again experience psychosis because of the context of trauma, grief, and other outstanding life factors, who may not have a diagnosis, who may not have the resources for any of that, or who do and didn't receive the proper care that they needed. It's it is a great option that needs to exist in every community. So I really kind of center it there. I don't know if that answered your question fully, Caroline. I feel like I said so much in such a short period of time, but please let me know if it did. Okay.
It did. I was wondering about your the numbers.
Oh,
Would we
data
have numbers
specifically.
work for you, or was it more necessity, just like a practical insight?
Do you mean numbers as a number of people we've engaged, or do you mean data that pre-exists from research and studies? Like, what are you?
Well, how like wait, I'm assuming you have a house. I mean, excuse me for not
Yes.
being more knowledgeable. I haven't done my homework about you.
Yes.
But how many people can you have at one time? A bit of
Oh,
a
okay. Of course.
staff ratio. Just what do you think works well, or was it
Oh,
predetermined
oh,
out by
I
outside
see.
factors, or was it your desire?
I see. I see. So the initial research study was 12 people at a time. We went for half. I think six, five can work well in a house. You don't want to have too many guests because I think once you reach a ratio that is like much larger, it's a lot harder to maintain a true community engagement approach. It becomes more challenging to maintain community engagement. There is this for us, it is five guests, three staff, three people working at a time, certified peer support workers for us, um, psychiatrists on call available, and licensed mental health counselor on call available, and then two managers across three shifts. So it's a total of 11 um, FTEs, full-time equivalents in the business world, but employees. And then you have five at the house, but really they're going to see like 3 to 4 people at a time. And that's kind of the ideal ratio. So that way, if two people are really struggling, or more, they can get the support they need from others who are there at that time. If they need to step away from, like, let's say where we're doing art journaling together, which is something we love to do, or we're in a peer support group, or we are having a discussion or doing an activity in the community. We go to the farmers market on Saturdays with some of our guests right now. If let's say they're struggling and they're like, this is too much for me, I actually need to go back to the house. Having three really, really helps in that way. So I hope that answers your question. And
Thank you.
excellent. Thank you. All right.
Thank you. Thank you, everybody. One question: the importance of relationships, and I noticed you had peer certified staff. Sorry, could you explain what the training is? How you
For
actually.
sure. For sure. So I will say for peer support, there are certified peer support trainings, and then there are trainings that aren't certified. And I always like to say peer support exists at the kitchen table. It exists at the barber shop, the hair salon, the community center, anywhere around you. You engage in peer support all the time in your life. Certification is the aim of like formalizing practice in a little way, in some ways. And um, there are also trainings that can support you in formalization of practice without necessarily engaging in the profession. Because we believe, I would say broadly, when we talk about peer support, that there needs to be grassroots effort. And then there also are people who are certified who work in many different places, jails, prisons, hospitals, on the streets, supporting people at several different points in time. So the training, what it often looks like is a history of the consumer survivor ex-patient movement is a module. So the civil rights history, training on the way that we train certified peer specialists is we focus on three core principles. One is being in but not of the system. Who are we of? We are of our communities. Two is being an agent of change, utilizing sharing your story and experiences as a methodology for advocacy and doing the work of advocacy, but also supporting the person and creating meaningful relatability and reciprocity, right? You receive from the people you support as they receive from you. And then three, being peer support, which is actually just the practice itself, connecting and relating on mutual experience and understanding. Um, the certification trainings that we offer have 63 hours of training, a midterm, final exam if you want the certification. If you're not looking for the certification, we also have trauma-informed peer support. There's intentional peer support. There are various approaches that exist that talk about peer support from a cultural and grassroots level about how do you do this work and how do you support people who are struggling with what society often labels as crisis and instead think of it as an opportunity for healing. Um, that is the work of peer support. So there are many different trainings for it, but I hope that that kind of gives you an idea. There are tools as well to engaging and working with someone, kind of like navigating what the problem is first, the impact of the certain decisions they make, the benefits of certain decisions they make, and then kind of brainstorming action steps together. There are many different approaches in that way.
Thank
Yeah,
you.
IPS is an example of one that is easier to sustain values. State certification it can be more challenging. It's not impossible, but it's more challenging. Thank you, Berta.
Well, thank you, Vesper. We still got a few minutes if anybody wants to ask us some more questions. Um,
I will say on this note that Berta had shared something that we do at Kiva as well. We are an Indigenous-led organization. So our chief executive officer, she's from the Santo Domingo Pueblo. She is of the Kiwa people, and I am of the Taino people of the Caribbean. So we do peer support as an Indigenous practice, as a training. And we do that for people certified or not to recenter on values prior to Western culture systems as you were describing, Berta. Caroline, I see you have your hand up again. We will add you.
Sorry, I'm very good at asking questions.
Okay.
I wonder if you had any insight about violence, because there's a lot of around psychosis, at least even though my daughter is not violent in any way, but the fear of violence or the perceived violence, and there has also been violence, and also the difficulty with communicating with people who are in trouble, or whatever word you want to use. I'm sure you're better choosing the right word than I am. I just wonder your insights about actual violence, but also perceived violence.
Mm. We cannot entirely prevent violence. We can mitigate it in any environment. Um, I will say in the United States, I can go to, there are some malls. Actually, in Massachusetts, there's a place called the Holyoke Mall. There was a shooting there the other day. People were injured. There's many shootings in places all over. Danger is difficult. I do think it is the function of what is sometimes called sanism, mentalism, and can broadly branch into ableism and discrimination that makes us perceive immediately that that all people with psychosis or who experience extreme states pose a danger to our society. Um, and the ways of mitigating this, you can move through in many different ways. I do think, you know, we do have a lot of nonviolent conflict resolution trainings that our team takes. There's a lot that body language does. If someone can see your hands when you step back, you show an open to take enough space from a person, talking these things through. There are there are self-defense trainings that people can take if they do feel like there's a weapon involved or immediate dangers. Without restraint, no utilization of restraint or locked doors. That is a core philosophy of Soteria. Um, so there's that, and then there's perceived danger, which I think exists more broadly than actual incidents of danger. And I can tell you that as someone who has been doing this work for, at least in this context, 14 years, right? That Yes. Are there at times violent situations? Absolutely. Are there ways to mitigate and build environments of compassion and care and offer training to people that actually lead to less dangerous circumstances? Absolutely. Environment matters. If there's one sign that says I'm a flight risk and another one that says have a nice day, I'm not hearing have a nice day. I'm hearing that I'm a flight risk. Messaging is important. The way in which we convey and do these things is important. The culture of the space is important. Can guests in the house see the exits? Can they see their way out? Do they have enough awareness in the space? Or do they feel confined? Because when a person is confined, their response might be more aggressive. It is just more likely that it will be, right? So I think I usually talk about how these environments are set up, the types of training that our team receives, um, and I usually say that people once again they pose more of a danger without resources on the street than they do engaged in a resource like Soteria, with people who offer compassion, care, understanding, and reflection at space. Thank you, Caroline. Berta, and then I know we're at the hour, but we'll take Berta's question.
I apologize for talking so much. Oh gosh, I think I just forgot what I was going to ask.
Mm.
Oh, what is your process for your for staff supporting one another? because what you're offering to guests is both a gift and sometimes can be very heavy. So, how do you care for one another?
That is such a great question. Uh, so first, we have such a wonderful community. So I will say we train folks who don't work day to day on our team, but who are there in the event that we do have team members who need to take some time off, that we have what's called, they often call it a relief pool or per diem or how in the official sense. But what I like to think of it as is it's a community that cares and supports and does this work with each other. So that's one, training people who will do that and support that. And then two, how we support each other. We do take, retreats and times to kind of reflect, and then we have regular reflection. Sometimes there are many different approaches, but time at the end of the day, end of the week. We do trainings every Friday. I do trainings with our team every Friday. We did one last Friday on trauma, and we talked about traumatic experiences and a lot of the experiences that we carry, both in our own life and experiences that we've had, even in the environment doing this work. And I think it's hard when you have what's often defined as a traumatic experience in the community as a result of people in the community you care about who are looking for these resources, because you understand where their heart is. You just understand that they're also in pain, and you see them in pain, and you see that pain in yourself. And I think some of that training and taking time like that regularly, both on a weekly basis, daily basis, and monthly basis, regular check-ins every day, and short times for reflection, but then at the end of the week, taking more time to reflect, and then every month, taking either a day or so to really unpack a lot of it, and then maybe quarterly doing things like retreats and coming together and taking that time. That's how we structure our time at Kiva. That's not how the rest of the world works. It's sometimes very fast, but thank you for that question, Berta. Community care is important. Self-care is only a part of it, but community care is really where it is. All right, thank you. Thank you, Eamon, and thank you, Soteria London, for partnering with us on this webinar.
That's such a positive note to end on, community care and self-care. It's good in my cough. But thank you, Vesper, for just making the time to do this and all that great knowledge and experience of it all. And thank you, everybody, for attending. We'll be sent. I'm going to do some throat pastel self-care, love, in a minute. But thank you all. Come and hope to see you soon. In London, we're doing the kitchen, and we got an open mic event soon. But thanks very much, everybody. Bye.
Thank you all. Take care. Bye.